Hi, good morning, and sorry for the delay. Thank you, Chairman, for your kind introduction. So today I will talk to you about two controversial topics in Italy. First, lupus headache, and whether lupus headache is real or not. And second, therapeutic plasma exchange in patients with SLE, and whether we should use it for SLE-related diffuse alveolar hemorrhage. Starting with the case, this is a 32-year-old female who is known to have SLE and diagnosed in 2011. She presented with arthralgia and headache. There was no joint swelling on examination. She said that her headache is chronic and it happens about 4 days per week. Each time it lasts for 6 hours, and she has nausea with that. There's no vomiting or aura. And she was seen in private clinic, and she was told that she has lupus headache. She was advised to take a steroid, and she came to me for a second opinion. And the question is, what is lupus headache? When you look at the SLEDAI-2K score, the lupus headache is defined as severe persistent headache, which might be migrainous, but must be non-responsive to narcotic analgesia. The SELENA-SLEDAI defined lupus headache the same, and in the BILAG, they added that the lupus headache should last for 3 days or more, or any headache secondary to intracranial hypertension. In the ECLAM, they added that this lupus headache should be partially or totally responsive to corticosteroid. And you can see that there is no unified definition of lupus headache in the disease activity tools that we use. We all know that lupus headache is one of the 19 ACR manifestations of a neuropsychiatric SLE. And when you look back in the literature, lupus headache story started in 1978. Before that, it wasn't documented in the literature. For example, in 1975, an article talk about brain involvement in SLE, and headache was not a manifestation of SLE at that time. However, in 1978, lupus headache term appeared, and it was defined as a migraine that may be associated with vascular dysfunction in SLE. And since then, we had several studies that showed that the prevalence of headache might be higher in patients with SLE compared to general population, ranging from 30 to 65%. I believe this is the largest study that examined lupus headache in patients with SLE. This is a study that was done in 30 centers worldwide, and it was published in 2013. It included 1,700 patients with SLE. The prevalence of lupus headache was 1.5%, and lupus headache was reported in the SLEDAI-2K about 27 times out of 7,500 assessments. They said that lupus headache was not associated with disease activity, even though we give 8 points in the SLEDAI-2K score for lupus headache, and also lupus headache was not associated with any specific antibodies. When they looked deep on those patients with lupus headache, they found actually that those lupus headache actually meet the criteria for other types of primary headache. Using the International Headache Society criteria, about half of the patients actually had migraine, followed by tension headache, intractable non-specific headache, cluster headaches, or intracranial hypertension. So they found that lupus headache was not aligned with a uniform IHS classification for headaches, and there is a lack of consistency in diagnosing lupus headache, indicates a need to better define lupus headache and to reach consensus whether it's truly a standalone manifestation of a neuropsychiatric SLE. This is also a meta-analysis which looked at the type of articles published before 2004, and they divided the studies into 4 types, whether they are retrospective or prospective, and whether they use IHS classification criteria. There were no prospective study. Most of them are retrospective, like case controls or case series, and there were only 8 studies out of 35 studies that they used the IHS classification criteria. And when they used the lupus headache, there was no clear definition. And again, the authors always say that lupus headache is severe, disabling, persistent, and not responsive to narcotic analgesia. So if we don't have lupus headache, why some patient with SLE and headache then respond to steroid? And the answer is simple. These patients most likely have migraine and not lupus headache. This is a systemic review which looked at the efficacy of steroid in migraine, and you can see that steroid was higher than placebo in efficacy in treating migraine, especially for recurrent migraine. So if you give patients with SLE steroid for lupus headache and they respond, they might have migraine and not related to the inflammatory pathway of lupus. This is the pathway of migraine, and you can see that there are two ways in how migraine happens, neural and vascular, and both leads to inflammation, which leads to headache. And this makes sense why migraine patient responds to steroid. Finally, when you visit the International Headache Society and you look for lupus headache, you might find some headaches that are attributed to rheumatological disease like giant cell arthritis, primary or secondary angiitis, but there is no lupus headache. It doesn't have an ICD code. And also you can find other types of funny headache like cough headache, exercise headache, sexual activity headache, or cold stimulus headache, but lupus headache is no place to find. So what we can say that the literature lack a conclusive evidence to establish lupus headache as distinct entity. There is no such thing as lupus headache. Moving to the second controversial topic is whether we should use therapeutic plasma exchange for all patients with SLE-related diffuse alveolar hemorrhage. Again, I'll start with a case. This is a 19-year-old female SLE patient presented to ER with shortness of breath and hemoptysis for 2 days. And you can see that the patient has malar rash and arthritis, no fever, and her current medications include Plaquenil, prednisolone, calcium, vitamin D, and esomeprazole. Her chest X-ray showed bilateral patchy opacification, which goes with a diffuse alveolar hemorrhage. The patient was intubated because of low oxygen saturation, and the first impression was that the patient has diffuse alveolar hemorrhage. She was given pulsosteroid, and the team was planning to give immunosuppressive medication once infection is ruled out. And the question is, would you add plasma exchange for this patient in addition to the steroid and immunosuppressive medication? This is the ASFA guideline, or the American Society of Apheresis guideline, and they listed lupus as indication of plasma exchange, and they said that the lupus should be severe, and they define severe as refractory and or organ failure, which include diffuse alveolar hemorrhage or other manifestation like catastrophic antiphospholipid syndrome. The category of recommendation is 2, and the grade is 2C. And grade 2, they defined grade 2 as disorder for which apheresis is accepted as second line of therapy, not first line. And when we look at grade 2C, it was defined as a weak recommendation, low quality or very low quality of evidence for using plasma exchange in patients with SLE. And this is because there were only 2 randomized controlled trials for plasma exchange in SLE patients, one in the 1980s for mild SLE symptoms, and the other was in 1990s for severe lupus nephritis, and both trials failed. There was no improvement of disease activity in those 2 trials. And when you visit the EULAR recommendation 2023, plasma exchange was not listed as statement recommendation. However, it was mentioned in the text. It said here that patient not responding to any of the aforementioned therapies might offer other options such as plasma exchange. And what they mean of the aforementioned therapies like cyclophosphamide and rituximab. This is a systemic review which looks at the literature for using plasma exchange for patients with SLE, and you can see that the number of articles represented in the blue bar increased from 8 in 1980s to 20 between 2000 and 2013, and you can see also the number of subjects increased from 19 to 80. The overall mortality didn't change. Always the mortality of patients who have diffuse alveolar hemorrhage and SLE is 50% from 1980s to 2013. And when they looked at the efficacy of plasma exchange in these articles, they compared those who received plasmapheresis with those who did not receive plasmapheresis. For subjects who had diffuse alveolar hemorrhage, there was no difference in the survival rate between those who received plasma exchange with those who did not receive. And when they examined the efficacy based on the episode of diffuse alveolar hemorrhage, also it was not effective. For cyclophosphamide, the efficacy was seen in those who had higher episode of diffuse alveolar hemorrhage. Survival rate was significant, 71% versus 49%. So we can say that the use of cyclophosphamide appeared to be associated with better survival, whereas plasmapheresis did not improve the survival rate in patients with diffuse alveolar hemorrhage related to SLE. Possible explanation is that the double-stranded ENA is not responsible for alveolar hemorrhage, or maybe the antibodies are already bound to the alveolar capillary membrane at the time of presentation. Other explanation is that there is a rapid rebound of antibodies and immunocomplex to pre-treatment level after the total plasma exchange. This is also another study which includes 90 patients. They did autopsies for those patients, and they looked at the pulmonary involvement in those patients. The most frequent finding was pleuritis. They included 23 patients who had diffuse alveolar hemorrhage, and when they did the biopsy, there was only 3 out of 23 patients who had capillaritis. They didn't comment about the immunofluorescence results, and they said that 1 patient died because of alveolar hemorrhage. So there was only 3 patients who had inflammation causing alveolar hemorrhage, and the others did not have evidence of inflammation. And the question is, what could be the cause of pulmonary hemorrhage in patients with SLE? There are 2 hypotheses in how alveolar hemorrhage happens in SLE. One is bland hemorrhage, and in these cases, there is apoptosis of the epithelial cells of the alveoli, and there is no immunocomplex or inflammation involved in these patients. And this is the majority. So the majority of patients had bland hemorrhage and not capillaritis. In the minorities, they had capillaritis, which immune complex involved in the pathophysiology of this patient. And the immunocomplex followed by a neutrophils invasion. So this makes sense that patients who has diffuse alveolar hemorrhage and SLE, the majority of them have bland hemorrhage and not capillaritis, and this is why plasma exchange doesn't work. Another interesting finding that infection was common in patients who had diffuse alveolar hemorrhage, including opportunistic infection like CMV. Finally, we have to remember that when we use plasma exchange, we use anticoagulation. We use heparin and citrate during the plasma exchange. And it doesn't make sense. We're using anticoagulation for someone who is already bleeding into his lung. And this is like adding wood to the fire. Also, we are draining the hospitals of the resources, and plasma exchange is expensive. For each session, it costs about $2,900. So in conclusion, we can say that lupus headache is a myth. Lupus headache was invented by rheumatologists, but the neurologists didn't buy it. When evaluating patients with headache, we should rule out secondary causes like sinus vein thrombosis and septic meningitis. Using therapeutic plasmapheresis to treat SLE-related diffuse alveolar hemorrhage is controversial. Therapeutic plasmapheresis is not recommended as first-line treatment for SLE-related diffuse alveolar hemorrhage, and infections are common with SLE presenting with diffuse alveolar hemorrhage, hence early antibiotic coverage is advisable. I know that some of you might not agree with me, and I know that my impression about these 2 topics could be wrong. This is why I would like to share a quote by Imam Shafi'i, رأي صواب يحتمل الخطأ ورأي غير خطأ يحتمل الصواب. My viewpoint is accurate and prone to error, and others' opinions are wrong and prone to correctness. Thank you.
Thank you, Dr. Naif.